Hello and welcome back to The Halfway Point. Today we're talking about how we can use smarter systems and technology to help improve our monitoring and recall processes within our practices. And I'm delighted today to be joined by Mark from MedLink. Hello Mark, do you want to explain briefly what your role is in MedLink and a little bit about MedLink?
Sure, yeah. Hi Ben, thanks very much for inviting me to join. My name is Mark Widgery. I'm a GP and one of the co-founders of MedLink. So started MedLink with a fellow GP and co-founder Lawrence Kemper back in 2019, and we have been developing systems for initially online reviews and now automated recall and monitoring, marketed to our colleagues in primary care.
So you're perfectly placed today for today's discussion then. So what I wanted to explore today was kind of where general practice sits with monitoring and recalls. It's fair to say the demand in general practice as it's not slowing down. Long-term conditions, the number of patients that we're adding to these registers are growing almost daily in some cases, and the monitoring requirements are kind of stepping up. So teams are already feeling stretched. What would you recommend is a good way to start with just looking at the monitoring process for a practice? You know, if we were starting from scratch today, where would you start really?
I mean, I think the first thing to say, you're absolutely right. It's a big issue for practices because, I mean, certainly in terms of monitoring of DMARDs, DOACs, levothyroxine, all of the drug monitoring that we do, the CQC is really hot on this. And in fact, there are publicly available data that shows that it's a significant point of the CQC kind of analysing and monitoring practices themselves for their quality of doing this. And I think the big issue with all of these processes is that as efficient as many of the processes are that work within the clinical systems, they're all very manual. They rely on an individual in the practice running manual searches, identifying the patients, either for long-term condition recall, which is one of our products, or for kind of drug monitoring, which is our new product. And I think what we've aimed to do is we don't want to take control away from practices. What we want to do is to take away that day-to-day busy admin work of actually running those systems. So the way we always pose this practice is we want to give you control over how the system runs and how it works, but we want to take away that daily running admin staff running searches, sending out invites to patients, chasing those patients up. It's a hugely time-consuming exercise, and that's the discussion I have with practices all the time. And to say we can actually we turn it into what we call fire and forget. We want you as a practice to be able to configure the settings, tell us what you need, and then we can actually run that system for you in the background. So that's what we feel actually improves the quality of clinical care and its consistency, and massively reduces particularly the admin burden to practices of running those both drug monitoring and recall processes.
So what do you kind of see as some of the biggest pressure points then? Where are, if you like, where the practices are struggling then? You know, you mentioned about some of the manual processes, but is there ways where the practices are kind of seeing the woods for the trees? I think I'm guessing is how to step away from the anxieties they might be facing now about making sure their recall processes and their monitoring are accurate. Kind of where would you recommend they start, especially going from a manual spreadsheet type approach to going to something more digital like MedLink?
Obviously, what we're doing is trying to build something that we want in our practice, and that's really how MedLink started. We built something that we wanted for our practice, and in fact, our very first customers were patients of ours who were clinicians elsewhere, but actually patients registered at our practice, getting our online reviews and contacting us and saying, hey, look, you know, this is good. Can we have this for our practice? And so what we're aiming to do is to say, okay, we know, or you can tell us what you need for practice recall, how you want to structure it. You know what you need for monitoring. And really the kind of the core functionality that we have is the ability to read. So we're integrated with EMIS Web. We can read and analyze the EMIS record. We can interact with patients directly via NHS app, email, SMS messaging, including self-book links for appointments. And we can then analyze the record to look whether that patient has completed the thing that we identified as being needed. And it's that combination of those features that allow us to automate both the long-term condition recall process in a kind of annual review process, and also a new product that we're releasing, which is the automated monitoring for sort of high-risk drug monitoring. So I think when we talk about automation in this way, it's not about taking away control from the practice. It's all about them saying, this is what I need to happen, but actually not relying on the one member of staff who knows how to do this and everything falls apart when they go on holiday or when they're off sick, and taking away just that day-to-day administrative burden.
Yeah, I was just going to add about when these systems rely on individuals rather than structure, the risk is huge. And you've just identified that really well. So I guess expanding on that then, kind of what does smarter working really mean? So exploring some of the system solutions then. So the automated recall systems, and then linking that back in with the clinical systems. What is the patient journey, I suppose, from once the practice takes on something like a MedLink? What happens next? What's the patient journey from start to finish with these, and what's the outcomes that you see?
Yeah, so I think in terms of Recall, which is our existing product that's been in place for about 18 months now and is very well established. We're live currently in MedLink and about 300 practices across the UK who are using our services. So the aim of this is that as a practice, when you start MedLink and you set the system up, you configure the scope of the recall system. You determine which conditions are included and exactly how that's structured as a practice. And essentially you tell us, I want these conditions to be monitored on an annual basis. We use the patient month of birth as a trigger for that process, just because that's quite commonly used and it's easy for patients to understand. So the way our process works is that you configure that setting, and then basically you can fire and forget. You can leave it alone from an admin point of view. When the patient's month of birth comes on a particular day, we actually run an analysis of their record based on the practice settings, identify for that individual patient all of the relevant conditions that they require for review. And I think you alluded to it earlier, the complexity of multimorbidity and how do you kind of prioritize the different conditions and manage that in a meaningful way, particularly with online reviews, has been a real issue that we've faced. So what our system does now is identifies within that analysis all of the relevant reviews and actually builds for each patient a personalised multimorbidity online review for the patient, built specifically for their needs. So rather than getting a single condition, here's your invite and your online questionnaire for your asthma or your diabetes, it's actually a single multimorbidity questionnaire for that patient, built for them specifically. We then automatically send an invite to the patient, NHS email, SMS, containing a link to their personalised message, and we code that invite to the record to make sure that there's an audit trail of everything that's been done. Patients then, if they choose to engage online, the majority will do so. We send a second invite to patients who haven't engaged to make sure that it fulfills QoF requirements and code that second invite as well. And so from a patient perspective, as a patient, I receive, I've got asthma and diabetes, I receive the link and I go through and I answer all the questions. It's a simple online questionnaire, either on my smartphone or a tablet on a computer, and I answer the relevant questions. And we've built what we hope are really high quality and clinically engaging online reviews for patients that are, as well as gathering data from patients, we're also sharing relevant information with patients in a kind of education. And then once I actually submit that as a patient, then the analysis of my record has also identified whether I need blood tests, foot check, urine ACR, other components that can't be done by me on a phone at home that needs something further, typically an appointment arranged. And so at that point, I will then, as well as my response going into the practice, kind of in a pending part, I will then be prompted to arrange an appointment to get my A1C done and my foot check done. I can do that directly with self-book, and I'll receive reminders if I actually don't engage with that process. And our system will then check the record each day and look for those codes to be present in the record. Because what the diabetes team wants inside the practice is a full data set. I want the answer to my questions, but they also want my blood results, my foot check, my ACR results. And we need that. And so the system looks for those, identifies when they're complete, and then flags them to whoever the practice is assigned to look at that response. And so one of the big impacts in terms of the long-term condition recall process is, rather than the kind of traditional review due, here's a self-book link for an appointment, what we're doing is saying, review due, here's a questionnaire. We're asking, as a patient, I'm being asked a bunch of questions, including at the end of that questionnaire, how do you want to finish your review? Do you want to discuss things further? Or are you happy to complete your review without further discussion if appropriate? And if I choose that second option, which most patients actually do, and my clinician agrees when looking at my responses, including all my blood tests, that that's appropriate, then the practice, the staff, by following up simply by a message to me, is doing exactly what my preference is and what they consider to be clinically appropriate. And so doing that in a way that's very time efficient. So just to give an example, within our practice, about 70% of our asthma reviews are completed entirely remotely, and we've timed our nursing staff. It takes about 3 to 5 minutes of clinical time, sitting in front of that response, configuring the asthma action plan and following up with the patient. And that's a genuine, thorough, high quality review that replaces a 20-minute nursing appointment, but is extremely efficient. And even when follow-up is required, so let's say that the nurse identifies some issue or the patient wants to discuss things further, that consultation, when it follows up by phone or in person, is very targeted and very time efficient, because all the transactional work's been done. The data's all coded. There's no working through a template. All that stuff, that busy work that happens in consultations is all done. And what you're focusing on is the real clinical nugget of what do I need to deal with for this patient that they've identified or that I've identified. And so we see this as in some cases, it's completing the review entirely remotely. In some cases, it's actually gathering data in advance of the consultation, but even then it provides efficiency. So that's the kind of patient journey. So it's using that questionnaire. We often think about it in terms of risk stratifying your patients rather than reviewed you, here's an appointment. Reviewed you, risk stratify my patients based on both their preference and the clinical status that I judge, and then determine whether or not a subsequent follow-up consultation is required at all. And in many cases, it's not, particularly with our, with well-controlled patients. And that's something that I think patients really appreciate because they are happy to engage online for the majority of patients. And so we see real both admin savings in terms of the arranging the process, but also particularly clinical capacity release when it comes to actually dealing with these things via remote reviews in the majority of cases. So that's kind of where MedLink sits. And then from a patient perspective, if I feel my asthma is well controlled, my clinician agrees that it is, I get a follow-up text message within a week or two, depending on the practice. There's no urgency with this, saying, thanks for completing your online review. Any concerns, get in touch. Our practice sends hundreds of those. That's completed the review. The entire, in this case, asthma review is done. All of my QOF requirements are in the record, and that's completed the cycle. But actually, the total amount of clinical time, for the practice is we're talking 3 to 5 minutes. And the total amount of admin time is 0. So that entire process from beginning to end can happen with 0 day-to-day admin input whatsoever, because MedLink's doing the search function, inviting the patients, and gathering the data, and then writing it. So then once that's completed in the practice, that data's all written to the record. And so what we're trying to do is we're not doing clinical work on practice's behalf. We're never making decisions on their behalf. What we're doing is we're gathering the data on a practice's behalf, and we're making that decision-making focus as efficient as it possibly can be for their clinicians.
Following the success of LPM's very first New to Practice Manager Conference, we are bringing them back with dates right across the country. This year, we're heading to Hull, Salisbury, Newcastle and Preston. And the best part, it is completely free to attend. If you're new to the practice manager role and feeling like everyone else has the manual except you are not alone. These conferences are relaxed, practical and honest. Real conversations, useful learning and tools you can take straight back to your practice. You'll also meet trusted industry partners, leaders in their own field who are there to support you and help you grow with confidence. You will leave clearer, better connected and ready to lead. Head to locumpm.co.uk to book your free place and follow us on LinkedIn and Facebook to stay up to date. We would love to see you there. You mentioned it just there, the stable patients, so sticking with asthma. We had what was effectively hard to reach patients where they were stable asthmatics, but they'd never come in for the review. And in fact, they didn't need to, And all of a sudden, we're hitting those patients with MedLink because they're doing it on a Monday evening. They're sat at home. The kids are in bed. They've done their review.
The cost of the patient in that case is extremely small.
Having the resources available. So, the inhaler technique videos and stuff like that as well that the patient can then refer to. And actually, I'm not too sure if I am using my inhaler right. Right, come on in. But then when they're coming in, they're only coming in for one thing. They're not coming in for, a shopping list of things to check that they've already, they've already gone over it.
Well, and it's interesting, you mentioned the kind of the hard-to-reach patients. This is actually probably the thing that really got our clinical team and our practice on board right at the very beginning, because our very first mail-out, literally the first thing we ever did as a test pilot for MedLink was we found a cohort of patients who'd ignored, at that time, 3 invites a year, and over 2 years, so 6 invites completely ignored. So basically a profoundly disengaged group of a few hundred asthmatic patients in our practice. Texted those patients with a link to our very first version of our online asthma review, and we had an overall 55% response rate from that cohort. So what it shows is that you're never going to engage everybody, but if you say this is needed, and actually this is easy to access, this does not require an appointment, this does not require waiting in a waiting room anytime, this is 10 minutes on your phone, answering some questions and sending us in some data. And so what kind of happened within our clinical team is that what we've always found is that well-controlled patients are also very compliant. So, you've got your asthmatic cohort, extremely well-controlled, do everything they should be, but also come in every time they're invited. So they come in for a lovely 20-minute chat with the asthma nurses with very little clinical yield. And what happened is that group could be managed very efficiently with the online system. And actually, we got engagement from patients who otherwise wouldn't come in and are then able to follow up with them and actually genuinely improve their control. And so that shift in clinical focus from the well-controlled, well-behaved to the other end of the clinical spectrum is really what got our clinicians on board with the online review process at the very beginning. Yeah.
And I think that 55% uptake is an amazing figure. Like you said, you're starting from nothing. So bold expectations. So, and I think that illustrates further, when you look at the 10-year plan and everything, it's modern general practice. It's, we've got to go to the patients now. It's no longer implied that the patient will just turn up because we're the doctor's surgery. We've got to go to them. And so, you've done that through going through them virtually. And so I think expanding on then, so on the recall side, seeing the kind of roadmap and what's coming next, the drug monitoring side of things. So same process in principle, I guess, around with the recalls, but explain to us how can the drug monitoring process, especially digitalizing this, how can that help save a practice kind of time and resources?
Absolutely. So, I mean, this came about very much because of client feedback. So, almost every demo I've done, really for the last year, and we're talking hundreds of things, but we'll explain the process that we can do. We're kind of doing an annual single recall process, but we're analyzing the record, identifying all of the conditions, and questionnaires, self-book, and you can see the cogs whirring, and people say, "Hey, can you automate my drug monitoring as well?" Right? Like because all of a sudden, if we can do all of those things, why can't we apply it to this particular domain? Which people are absolutely right, and that's very much been our focus. So drug monitoring is slightly different, whereas annual long-term condition recall is very much focused around the kind of annual analysis within a patient month of birth. The drug monitoring is a much more ongoing process. We're doing a regular periodic analysis of every single patient's record in the practice, identifying, and so we talk about monitoring in two broad groups. So one is what we call group monitoring, which is basically automatically triggered by the record, and the other, which we'll talk about later, is what we call individual monitoring. So the group monitoring is probably the most powerful, and that's really the DMARDs, DOACs, levothyroxine, all of the drugs, and actually some other conditions, so celiac, MGUS, and gout, for example, that are monitored often quite poorly, actually, but should be being monitored. So the setup is very straightforward. What you're doing as a practice is you can actually do it in, it's about 2 clicks. You basically turn on everything with the default frequency. So we literally have a setting that says, methotrexate, I want a full blood count, use and ease, LFTs, every 3 months for my methotrexate patients. And that's the setting. And so every time we do an analysis of the record, we're looking at the clinical coded data, including the medication. So we're identifying all the medications the patients are on. We're looking at checking they've actually been issued within the last 6 months to make sure this isn't kind of historical data. If a patient is on methotrexate and we identify that they are, we then look at, okay, when were their last blood results due? When were their last blood results done? We look in the record, and we then can work out when they're next due. So we do that all automatically, and you can actually look at individual patients and see all of their monitoring requirements. And then when something becomes due, we then trigger what we call a monitoring episode. And this triggers then invites being sent automatically to the patient directly, again, via NHS app, email, SMS. And what it does is then invites them. It's a self-book link, so it's simpler in a sense from a patient perspective than the recall, because there's very little focused on kind of questionnaire type format. It's primarily about investigations. This is about blood tests and other a few other things, but primarily bloods. And so, for example, your methotrexate patient, instead of having to be running the searches, sending out those invites, checking it's being done, our system does that fully automatically, sends out that invite, invites them again a week later if they haven't engaged with that. And for the majority of patients, they sit in a dashboard, which is visible to admin inside the practice. But if they follow that process, they book in, it shows that they booked in, they get their blood results back. We then analyze the record each day looking for those results. And once they're in the record, we mark that episode as complete, and the entire process is run automatically. So what we're really interested in as a practice is I want my admin staff to do as little work as possible. I want that to be straightforward. What I want them to do is to come in and only see the patients who either need something manual done, or who haven't followed the process and are not disengaged. And obviously it's a practice decision how you manage those, and it may be task the usual GP, or it may be contact the patient directly and actually call them and remind them what's needed. But what we found with this is the vast majority of patients, because they're used to this, particularly patients on DMARDs, they do the 3 monthly bloods. Yeah, it's a pain in the backside, but they know it needs to be done. And so this is not something that's new to patients. This is not something that's coming out of the blue. So, but the system just then runs in the background with that automated process. If the patient stops their methotrexate or changes to a different DMARD or whatever it is, then we pick that up and we obviously change, if appropriate, we change those intervals. And so that system just runs in the background. But the key thing, actually, and what we've spent probably most of our time in the development of this, is that if the DMARDs are due now, but the levothyroxine, TSH is due in a week's time or even a month's time, what we all want is to consolidate that into into a single blood test appointment, right? And our principle has always been, we say this to our dev team, if we're sticking, or if the practice is sticking a needle in an arm, we want to do everything we possibly can at that moment. Because what irritates patients, justifiably irritates them, is, blood test now, and then, hey, 3 weeks later, you're due a blood test. And the patient quite rightly says, why on earth didn't you do this before? And what that involves is not just saying what's due now, but actually looking forward, knowing what's going to be due. And so what we've done is we've determined a kind of reasonable period, what we call pull forward, of basically looking forward and saying what's due within the next X period of time, and can we reasonably bring stuff forward? If something's due annually in 11 months' time, then nobody wants it. It's only a month old. We don't pull it forward. But if it's annual and it's due in, say, 2 months' time, I think it's very reasonable to then pull that forward. So that's the process that we've done. We want to consolidate that. And when we do a single, particularly blood test episode, we absolutely maximize that and avoid both patient irritation and practice inefficiency. So that's been a real focus of the system. And because that's comprehensive, i.e. all of your monitoring is run within our system, we know that everything that's needed for that patient is then, you've told us what's needed, and we can bring it forward if appropriate and get it done in that single sitting. And then we've also built it to run alongside the recall process. So, for example, if you're on methotrexate monitoring and your annual recall is due in 6 months' time, as part of the settings, the practice say, look, I want an ACR and an A1C within the fiscal year for this diabetic patient. We know if that's going to be valid for that future date, and so we can actually arrange that in advance as well for the recall process. So this is all about, again, the principle of needle going in arm, do everything you possibly can for that patient. And I think that's one of the real keys to the process, is because all of these systems built within our system, we know exactly what's due, we know exactly when it's due, and we can look forward and basically bring stuff in advance where it's appropriate to do so. So that's really I think one of the key components of the monitoring is to consolidate that, to avoid patient frustration and practice inefficiency, and to make sure, because ultimately what we're all interested, when I'm sitting in front of my prescription signing and I get to the DMARDs, I get to the levothyroxines, what I want to do is just know that when I hit F11 and find the investigations, the results are there and are in time. That's what I want. All of the clinicians want. We can't guarantee that's going to be the case, because some patients are always going to essentially say no or just not engage the process, but the vast majority will, and it massively then reduces the kind of admin burden needed to then follow those patients up and remind them that their bloods are due or whatever it may be. We just want that process to run automatically in the background. So that's the monitoring product. We're finalizing a few details with that. We've got it running within our own practice at the moment, and we're planning to launch that to our existing clients and also to any new clients in May of 2026. We're excited about the impact of that, because it has a really big impact in terms of it's a big admin burden for practices.
How do you find it when implementing these kind of systems into practices? Kind of how do you avoid overwhelming the team during changes like this, when it's very digital focused, especially if you come from a very manual spreadsheet-esque kind of way? How do you find that?
I think our principle has always been, we want to give control to the practice, but to minimize the kind of day-to-day work that's required. And so ultimately what we're not doing is giving lots and lots of we do give reporting, but I don't think what the practice is primarily interested in is lots and lots of kind of admin reporting. What they're interested in is actually stuff happening automatically without needing any manual input, and only being flagged when something manual needs to be done. So that's always our principle. We do as much of the work on your behalf as possible, and where things, and there are always going to be some patients, there are always going to be some scenarios that can't be automated, we then highlight that very clearly, so that instead of your admin staff being faced with all of these patients and all of the monitoring, here's the 1-3% that needs your direct focus, and making that process as easy as possible. So to give you an example, we launched this beta testing in our own practice and realized that it's not appropriate to be sending self-book links to patients in care homes, because that's just not how the process runs. But each care home typically will have a process that is in place for bloods. If it's a nursing home, it may well be a list sent to the practice by email saying, here are the bloods that are needed for your residents. And so we're actually building a specific automation where a practice can say, right, for patients in this particular care home, I want you to send notification of monitoring requirements to this email address with a list of patients, so that the nursing staff in the care home can actually get those bloods done. So again, this is about taking automation of that process, not just with the self-book links for patients, which is the majority, but actually automating, same with end-of-life care patients. So we're trying to build what we call protocols to say, okay, rather than your staff going through a repetitive process, doing the same thing each time, how can we automate that for you? And actually, one of the most exciting elements of this, which we have in place now, is that we can also, when we analyze the record and do the periodically for the monitoring process, we can actually pull out EMIS diary entries as well. And so what we've got now is the ability, I mentioned it earlier, we have that's group monitoring, which we talked about, which is kind of the automatically triggered process. Individual monitoring is set up at the individual patient levels. PSA is the classic example, right? You get the letter from urology, this patient needs a PSA every 6 months indefinitely or until 5 years or whatever the time scale is. Here's the threshold for referring back. Now that data is often put into a diary entry, but it needs manual process every 6 months to do that, and then to reset it, to complete it, and all the rest of it. Our system completely automates that process. And the beauty of this is that what we can do is somebody can actually write in that diary entry, they'll put the PSA code and they'll type in exactly that, PSA every 6 months until, date or indefinitely, refer back if PSA greater than 10. What our system then does is it pulls that diary entry out of that patient's record and enters that as an individual monitoring item for that patient. So it would have it, and it automatically detects all of those elements. So we set it up as a recurring PSA every 6 months to start on the diary date, and it would have within the lab notification field a refer back if PSA greater than 10. And so the idea is that lab notification can be put actually onto the ICE or the lab request, because what I want when I'm looking at a result is I want to know what to do with this result, and actually having it right there is phenomenally time saving for me as a clinician. So that's kind of the process of essentially those diary entries can be input only. So the practice can carry on putting data into diary entries. We automatically pull them out of the record, turn them into one of our individual monitoring requirements. That has to be then manually confirmed by the practice, but the automated system is extremely good at doing that. So even, for example, if you write a blood test due and you write full blood count ESR CRP, let's say, for a patient with IBD, our system will actually read that text and will convert it into a suggested, here are the blood tests we think this patient is needing on this periodicity, and the admin staff will just confirm that, and it will then automatically do that. So every 3, 6 months, whatever the period is, it will arrange those blood tests for that patient. So you've got the group monitoring, which is triggered by typically medications and conditions in the record. You've got individual monitoring set up for individual patients. So you can do this with PSAs, DEXAs, ultrasounds, CA125s, all of the stuff that's really variable, that's not triggered by a specific code, but is set up at an individual patient level. And a lot of that will be done via the diary system being transferred in automatically. So that's the kind of scope of the monitoring process. And you can also do that for interventions. So, B12 injections for vaccines as well. So it basically is about anything that's diarizable, that you say, here's a date for a particular thing. Our system will automatically trigger that, send an invite to the patient if appropriate, and make it clear to the practice that is in process. So that's the monitoring part of this. And probably one of the biggest differences from the recall is it doesn't generate any of the kind of clinical time in terms of the questionnaires needing responding to. It's actually just generating a small amount of admin work for the staff to just follow up those non-responding patients. 98% it just runs automatically in the background. Patients follow those self-book links and it completes automatically.
Wow. I can see the possibilities of it from the practice point of view. It's like you said, it's freeing up the admin staff to focus on where the human touch is then needed.
Absolutely.
So I guess kind of in wrapping up then, how do practices reach you? What's the best way to kind of move forward if this is something that resonates with them? Where should they go next?
Yeah, we'd love to hear from practices. We do through various different methods. The main one is via our website. So if you go to medlink.co.uk, there's lots of information there, including sort of video intros and some written information about the system. And there's an expression of interest form there, which comes straight through to us, and then we call or email practices and routinely actually just arrange demos. And that typically takes about 45 minutes. For EMIS practices in England, we offer a 2-month free trial of the entire process. So both the recall system and once it's live, which will be very soon, the monitoring system as well. And the aim of that process is to give practices the opportunity to try it out, see if it works for their patients, for their practice. And then after that, we have it's an annual rolling subscription basis, which includes all the communication details. So there's no kind of pass-through costs. We hope that price is still very, very attractive and very competitive in the market. Very happy we can be contacted directly. We have a info@medlinksolutions.co.uk if we want to email us directly. And we also, will attend conferences. So I saw you at Best Practice London.
Did, yes.
back Best Practice Birmingham in October, and that's a really good opportunity to meet people and chat with them. But mostly it's really expressions of interest via the website, and then Teams demos, which we offer routinely. And then once practices actually register, we've got a support team who will routinely meet with practices and help with the setup, really talking through their own individual practice requirements and making sure, because there's quite a lot of functionality that we've built, and want to make sure for each practice they make the most of that for their particular requirements and the constraints within which they work.
Okay, that's really helpful. So just wrapping up then, thank you, Mark, for joining us today. You've given me a lot to think about and hopefully our listeners as well. So as Mark said, we'll put the details he mentioned around MedLink in the show notes for this episode. And so thank you again, Mark, for joining us. And for everyone else, hope you have a good week. And we'll see you next time at the Halfway Point. Thank you again, Mark. Thank you for joining us today for another episode of the Halfway Point. We hope today's conversations has given you a fresh inspiration and practical ideas you can take straight back into your practice. You will find all the links and resources we mentioned in the show notes at locumpm.co.uk. The Halfway Point is available on all major podcast platforms in both audio and video formats, so you can tune in however suits you best. If this episode helped you, we would generally love to hear from you. Leave us a review or a comment. Not only does it make our day, it also helps us shape future episodes around what matters most to you. Make sure you follow and subscribe so you do not miss next Wednesday's episode. And if you know a colleague who would benefit from this conversation, please share this episode with them. You can also connect with us on LinkedIn and Facebook by searching for the Locum Practice Manager. We're on YouTube too, where we share practical tips and tutorials for primary care managers. Until next time, keep moving forward, keep improving, and we'll see you again next week at the Halfway Point.